Okay. So first question is related to things that might aggravate the fascia. And it's directed to Tina, but I think some others of you might have something to add to it. What is the role that trauma plays in fascia health, particularly in people with EDS? So Tina, why don't you take it first?
Yeah, can you hear me? Yes, you can. So we saw that wonderful slide from Elaine Langevin and how they irritated the fascial tissue with carrageenan. And so when fascial tissue is traumatized, it starts to densify, like we saw in that slide, if you recall that. And then there are different modalities that can start to mitigate that densification process to keep that inflammatory process in check.
And I want to broaden this also, not just physical trauma, but emotional trauma. So, Jeannie, do you have?
Yeah, absolutely. So, fascia is a sensory organ. It responds to stress and to trauma. So I work with a lot of EDS patients who have trauma, and they experience this feeling of contraction and muscle spasming, and the shortening of the fascia. And that's why creating that environment of safety is so important, so that you can start to allow that release and help somebody feel safe in their own body again. But yeah, it can totally be impacted by emotional trauma.
I think one of the things that helped me understand that very well is not only does trauma increase that sympathetic nervous system activation, and then that causes that whole feed-forward loop, but I think the most helpful thing that my therapist ever told me is that trauma is a brain injury. And hearing it that way really helped validate that emotion, like the emotional trauma piece of that. That it was creating inflammatory changes, it was creating fascia contractions in my limbic system, and then being able to have treatment for that in a physical way with fascial work. I think it's undeniable. Probably anyone who works with fascia in here has probably had patients cry or have releases when we treat the physical body. So I think they're very much connected.
Did you want to add anything?
Actually, I was going to just add to what Brianna had noted in her slides earlier, where you have inflammation where the fascia attaches. And that inflammation sometimes doesn't switch off. Mm-hmm. Now, we've seen that with tiny dose steroid, it will switch it off, but unfortunately, tiny dose steroid softens ligaments, and that's why it's not so good. And while the prolotherapy creates more inflammation, it then allows a healing process to happen. But people often don't need the prolotherapy if they've had the input of people like Brianna and Jeannie and what have you. So if you can get into there early and make that tissue normal and allow that inflammation to settle down naturally, you don't need to see me or other people who do prolo.
So I think the take home is that both physical and emotional trauma can affect the fascia very much and for a long time. Great. Fraser, a question about whether prolotherapy can be used for craniocervical instability.
Yes, I do that all the time, and especially treatments along the base of the nuchal line, or where the muscles attach at the base of the neck, can help tighten up, and sometimes we have to go into the transverse processes of the neck and the supraspinous, interspinous processes. Please don't go anywhere near the spinal cord, that's just dangerous.
A question I suspect a few people will have something to say. So actually there were several questions about mechanical treatments for the fascia, so rolling massagers, foam rollers, those shockwave devices. So we're going to start with the scientific perspective. What are your thoughts about those devices for fascial restrictions, fascial injuries?
Right, so I'll give you the clinical as well as scientific viewpoint. So I have a lot of patients who will bring the devices in, and so that's what I encourage you to do, that this is a tool, and bring that tool into your manual therapist, your healthcare professional, and help ask them to teach you the proper application for your body. So how your friend, how someone else does it on the support groups is not going to be the same for your body. So please be specific. And they will show you what tissue you're treating. Remember in the talk that not all connective tissue is the same. It depends on the tissue you're targeting. So have your healthcare professional assist you with the tool. And I will let Jeannie go next because of that wonderful video. That wonderful video.
Yeah, I mean, I totally agree. Everyone's different and it has to be appropriate to each person. But things like fascial I think the fascia blaster, foam rolling on our tissue, I'm not a huge fan. If you look at the cornflower video, you see how the fascia responds to excess pressure. And for some people, maybe that's okay. But if you've got delicate tissues, like most of us do I really want to be putting that amount of blasting or, into my tissue? I'm not sure, especially with the bruising and everything that comes with that, I'm not sure that is an approach I would want to do. I'd go for a softer approach.
Anything to add?
Yeah, my 2 cents is that if it hurts, shouldn't be doing it because it's going to contribute to that centralized pain. I remember being like, hurts so good because I was an athlete growing up, but I was very mistaken. So I think anything that hurts is probably not the right way to go.
I have seen deep tissue massage cause injury, so gentle is best.
Okay. Jeannie, another question for you. How can people who with exercise intolerance, and I assume that applies to both people who fatigue after exercise and people who hurt after exercise, what are some strategies they can use so that they can work on their fascia without flaring?
Yeah, very important. And obviously that applies to a lot of us who have the exercise intolerance. So the beautiful thing about fascial-based work is that it's super gentle. And it can be done lying down, on your bed, on the floor. We don't have to be going cardio and crazy and getting our heart rates up. The fascia will respond to these super gentle movements, which is wonderful for us, right? We don't have to beat ourselves up. We don't have to push ourselves in the gym. So it's totally appropriate. I work with so many people, obviously, who have dysautonomia and ME and CFS and long COVID and all these things. They're all in the same boat and it works beautifully. So absolutely.
Great. Brianna, several questions asked about some of the other types of manual therapy. So John Barnes' type of myofascial release, craniosacral therapy for working with fascia. What are your thoughts about those as alternatives if they can't find somebody who does fascial counterstrain?
I think those are all fantastic. I think anything that helps your body feel better, feel safer, as Jeannie put it, is a great option to add. I think the benefit of counterstrain is that diagnostic modality. So even if somebody's been doing a lot of craniosacral, for example, or myofascial release, I think those are all great additional tools. And then maybe traveling to see a counterstrainer every once in a while would be a good addition to complement that treatment regimen.
And there's probably some personal preference as well, that some
Absolutely.
people just do well with one type of approach.
Absolutely.
Okay. Fraser, a couple of questions for you. Should people with MCAS be concerned about prolotherapy, a reaction, scar tissue buildup? And can you just explain the difference between PRP and prolotherapy, or the terminology?
Answer the first question first. Yes, I actually stabilize people's mast cells before doing a first test injection. So if someone's mast cell is in flare, I won't even give them a test injection until that's under control. That's a safety issue. The side effects of tetradecyl sulfate is there's a less than 1% chance of a sulfur rash from it, unless you have a known sulfur allergy, in which case there's a 10% crossover risk. For polydocanol, there's a less than 1% chance of feeling really under the weather for 24 to 48 hours, unless you have a known soap allergy, in which case it's a 10% crossover risk. If your mast cells are out of kilter, you can get abnormal results regardless. So I wait for them to be under control before I do the first test injection. And then I'll only do one and wait to see if they have a response. Most people won't, but if they do, it's much easier to get over the dose if it's a low dose to start with. Remind me of the second question again.
PRP, prolotherapy
sure.
terminology.
So PRP is platelet-rich plasma. You take off 40 to 60 mils of blood, spin it down, then take off the platelet part of that blood, which sits between the serum and the red cells, and that's what you inject into the soft tissue. So that's stimulating a reaction similar to the reaction of the agents of tetradecyl or polydercanol, and it seems to have the same response. And I say it anecdotally, but I say that because every person who's come to me who's had PRP, I don't have to inject the spot they've had the PRP. And likewise, if I send someone to a colleague who does PRP, they don't have to inject the spots that I've injected. So anecdotally, as in with a large number of patients, but not done in a formal head-to-head study, they appear to be equal to each other. It's just the cost of taking your blood off, spinning it down, and then re-injecting it is a whole lot more than the cost of just injecting the agent, which is a very simple mix-up. Very simple to mix together. I mix it always with anesthetic. The anesthetic I use is prilocaine, and that's because it's a very low reactivity to prilocaine as opposed to xylocaine or lidocaine, lignocaine is other names for it, which 2% of people with EDS react to, and again, that's a mast cell issue.
Great, thank you. Tina, we heard today that fascia has a role in interoception. Do we know anything about that in people who are hypermobile, or the role of fascia in interoception? Do you want to define interoception?
Yes, definitely. So interoception is how we're sensing ourselves and what's happening within us. And then there's exteroception, how we're sensing the world, and fascia has a component of both. We often like to divide the two, superficial fascia, exteroception, and then maybe deep fascia or visceral fascia, interoception, but it's likely much more complex than that. And these two inner systems interplay. And it's likely that what we're sensing in the fascia with the disorganization then is allowing us to possibly sense more of what is going on inside as well as outside. And the dysautonomia and the autonomic changes play a huge role in that. The superficial fascia, as well as the deep fascia, but the superficial fascia in particular, has huge autonomic innervations. Some of the studies show that we often see nerve fibers, sensory, free nerve endings. 40 to possibly 80% of these free nerve endings are autonomic. They're used for sensing inside, outside, cross communication, how our bodies respond, and then our central nervous system responds, our brains.
So the fascia may link to the autonomic nervous system dysfunction, that the mechanical characteristics of fascia may contribute to the autonomic.
I think it's safe to say it absolutely does. And we'll see that in complex regional pain syndrome, with the skin changes, the texture changes, the temperature changes.
Fascinating. Jeannie, a few nuts and bolts about elongating fascia. Things like, is there a difference between a strategy to elongate fascia and a stretch? How long should you hold it? How long does it last for if you've elongated something before it might start to recoil?
Okay. So as I said in my presentation, fascia doesn't like to stretch. So we don't want to force the fascia into holding these long stretches. It doesn't like that if you're not ready for it. I'm a huge fan of dynamic stretching. So moving in and out of a stretch, the fascia likes that, to keep things moving rather than holding these stretches. And I tend to think, as we were sort of looking at that photo of the leopard expanding, if we really think of this whole body expansion and the breath expanding through our whole structure, you can really get that sense of elongation rather than stretch and force. As to how long it lasts, I'm going to ask Tina that question. it's going to obviously start to recoil. If we elongate, you
And
are
it
going
might
to
depend on the autonomic nervous system, whether it's making those myofasciites contract. So
Yes.
there might not be a single answer.
Exactly, yeah.
Yeah, and then the hysteresis, right? So going beyond the point and what you're sensing and the elasticity in your own tissue and the stiffness, again, the differential stiffness of the different anatomic sites will be different.
A question for Brianna. Are there any risk factors for doing the counter-strain approach? In particular, someone asked about, are there any risks to vascular structures? But it is just in general, any patients who might be at risk who should be cautious about seeking that out?
Yes, so counterstrain is contraindicated directly over implanted medical devices. So I wouldn't counterstrain someone's cardiac region if they've had a pacemaker, for example, or over like a NJ tube or something like that. Also, people who are actively in a mast cell flare and have not ever done any type of drainage work at all, and their lymphatics are very stuck. I would limit the duration of the first couple of sessions to ensure that they don't have kind of almost like a die-off reaction. That's common terminology in like Lyme disease world, but basically sometimes the system can get flooded with all of the stuff that's just been sitting in the interstitial space for a really long time. And once we push it back in the system, sometimes people can feel a little bit fluish or a little post-massagey, if you will, after having that treatment done. So if someone has really severe MCAS, I typically encourage them to have an antihistamine or a mast cell stabilizer following treatment, and then we'll just stick with a shorter treatment until we find what works for their body.
Wonderful. I forgot to ask any TMJ questions, but this one I think several other people can contribute to. So a couple of people asked what we can do to manage trigger points. So there are manual therapies that you can do, so trigger point release, gentle manual therapies, a lot of the myofascial treatments. Dry needling is often helpful for many people. Other strategies that you guys recommend or use for trigger points, we'll just go down the line.
I prefer using a fascially sequenced methodology. So when I teach, I let people know it's not just one single methodology, it's whatever methodology you've learned. So if you're an acupuncturist, you might go along meridians. If you're a classically trained physio, it might be antagonist and agonist. I'm trained in different methodologies of fascial sequencing, so I'll go head to toe. I prefer to go into the deep fascia to wash out that inflammatory mediator. Those are my preferred methodologies, but there's no one way to do it.
So what your clinician is skilled at that works for you, okay? Any other brief ones? I got one more question I want to ask, so any other additions?
I was just going to say home things that you can do. I really like topical magnesium if you can tolerate it. I like topical CBD cream as well, and then supports like splints, braces, etc. can help put that fascia in a little bit shorter position and can sometimes help relax trigger points or tendon points.
And that reminds me some of the physical things of ice for a severe trigger point, heat for a mild one can also be helpful. Okay, last one, we're going to start with Fraser, but I think others will jump in. Is prolotherapy a permanent fix, or can it get loose again?
So for most patients, it is good until you have a new accident. So you can't stop new injuries from happening. So when someone, even on the rugby field, a rugby player or a gridiron player, for those who do gridiron, can have a shoulder dislocate with enough force. It requires less force for someone with EDS to be injured again. But for most people, they're good until they have a new injury. Some people do get a wear-off effect, but when I go through, they said, oh, yeah, I had a trip and fall and fall downstairs or something like that. So actually there was an injury that caused them to come back with the same spot and needing treating again. So it's,
and would that include cumulative trauma, like if they go back to slouching?
Slouching normally comes from when people have an injury. You're trying to get away from the pain. When you've got pain in the back, you go forward. If you take away the pain from the back, you sit upright naturally.
Until you hand them a phone.
Or if you, yeah. But
any kind of a re-injury, whether it's
it normally
traumatic
takes
or
a new
repetitive,
injury. Yes, it normally
so
takes.
it's not a permanent fix if they do bad things.
Correct. I do have some people who like to get fixed and then they'll go skiing, black runs, and come back to get fixed again. That's their choice. They're living their life, and that's most important, that they actually live,
Yep.
not just exist.
True. Yeah, and one thing that the physios often find is that if you have bad habits that led you to be hypermobile in that particular joint to begin with, and you continue with those bad habits, the prolotherapy may not be as successful as long. That it's not like it's a permanent repair, that you do still want to address the mechanical issues, biopsychosocial issues.
And that's why combination with our colleagues who help relax the tight muscles and tighten the relaxed muscles and allow the fascia to move properly and allow the muscles to move properly actually works together, and people heal faster with combination therapy than with any one therapy alone. So I strongly recommend that people visit our colleagues before they come to see me, and many of them don't then need to see me or other people who do prolotherapy, because actually you fix them first, and that's really good.
It takes a team.
Exactly.
And a wonderful interdisciplinary team. Thank you all. Thank you.